Hey guys, my name is Shruti Suresh. I'm a fifth year student at the First Faculty of Medicine, and today we're going to be talking about gastrointestinal pathology part 1. So the topics for this lecture are diseases of esophagus and diseases of the stomach and duodenum. So we're only going to be covering the non-neoplastic diseases. We're not going to be doing any of the cancers. Then we'll talk about inflammatory bowel disease, which is your Crohn's disease and ulcerative colitis. Then we'll talk about the other non-neoplastic pathologies of the intestines, and finally we'll talk about the malabsorption conditions. So diseases of esophagus, like you can see here, there are a number of non-neoplastic pathologies that can happen in the esophagus. Some of them, like GERDs, Barrett's esophagus, Achalasia, Diverticula, or varices, are more important than the other ones, but we'll go through all of them anyway. So in general, when you talk about diseases of the esophagus, a universal symptom that you can think of is dysphagia. So dysphagia is whenever you have difficulty swallowing. So dysphagia can be either for solids alone, like you're not able to swallow food, or it can be for solids and liquids. So food and water, both you're not able to swallow. So in general, if you just have dysphagia for like solid foods, then it means that there's some kind of internal obstructive lesion that's not allowing the food to pass through, which can be like a cancer or like a stricture or a web. Whereas if you have solids and liquid dysphagia, then that means that there's more of a motility disorder, such that like your esophagus isn't able to push anything down to the stomach. The other symptom is epigastric pain or heartburn, which is like this pain that occurs in the retrosternal epigastric region, which is also a pretty much universal symptom. So the first disease we're going to talk about is GERD. So GERD is when you have backflow of gastric acid due to inappropriate relaxation of the lower esophageal sphincter. Now, what does this mean? So usually you have this gastro-esophageal junction over here between the lower part of the esophagus and the cardia portion of your stomach. And this lower esophageal sphincter remains closed in between meals, so that when your stomach is digesting all the food that you've eaten, the acid doesn't go back up or the food doesn't go back up. But when you have an inappropriate relaxation of this thing, such that even in between meals it doesn't close completely, then all this acid that's present in the stomach is able to move up retrograde to the lower portion of the esophagus. Now, the mucosa of the esophagus is not able to withstand this constant acid that's coming in because it doesn't have anything to neutralize the acidity. So in that case, what happens is it irritates the mucosa of the esophagus, and it leads to the formation of reflux esophagitis, which is basically the fact that you have inflammation in your esophagus because of this gastric reflux. Okay, so the inappropriate relaxation of the lower esophageal sphincter can happen because of a lot of reasons. Like it can happen just in general because of some kind of neuropathy wherein like the nerves aren't working properly. It can be because of stress. It can be because of gastric distension. It can also be because of something known as a hiatal hernia, wherein the stomach is directly going into the esophagus and it completely skips the sphincter, which is something that we'll talk about later. Or lastly, it can also be because the esophagus is usually like able to clear off this reflux material. It's not that reflux never happens. Sometimes it is physiological. But if it's not able to clear this acid, then it can also cause the GERD to develop. So in general, there's a lot of risk factors that are associated with GERD. So some of them are here. So anything that increases your intra-abdominal pressure such that the acid can flow back is obviously a risk factor. So one of those examples is obesity or pregnancy. And in both cases, you have an increased intra-abdominal pressure. Other than that, like I said, hiatal hernia is one of the causes, or anything else like stress, smoking, alcohol, caffeine, anything that can decrease the tone of this lower esophageal sphincter is also a risk factor. So in general, when you have reflux esophagitis, you can either have erosive forms or non-erosive forms. So erosive forms as in the mucosa is actually getting slugged off a little, so which can cause bleeding, or non-erosive is just like there's superficial inflammation. So if you do an upper GI endoscopy, on macroscopy, you're going to see this picture over here, wherein you can see this is the gastroesophageal junction, which is usually not supposed to be this red. But over here, because of the inflammation and the hyperemia, the increased blood flow, it looks very red. So this is reflux esophagitis. So like I said, they would present with heartburn, dysphagia, and regurgitation. Regurgitation is when not only the acid, but the food also is moving up the lower esophageal sphincter into the esophagus. And this is exaggerated nocturnally or on lying down, because obviously if you take out gravity, it's a lot easier for it to like move up. So these are the basic symptoms. Other than that, if the acid actually moves up quite a way away to like your respiratory system, it can also cause aspiration of the gastric contents, which can cause aspiration pneumonia in some very severe cases. Or if it irritates your vocal cords, it can cause hoarseness. And for the same reasons, it can also have nocturnal asthma. And then finally, if it actually goes up to your mouth in very chronic conditions, it can cause erosion of your tooth enamel. One of the biggest complications from this condition is something known as Barrett's esophagus, which we'll talk about in the next slide. And also, like I said, if you have erosive esophagitis, the mucosa can actually erode, causing chronic bleeding, because of which you'd have iron deficiency anemia. So sometimes this is the only presentation. If you have GERD, then the first thing is that the patient can come in feeling very fatigued and tired. So you discover iron deficiency anemia, you do a GI endoscopy, and you see this. Treatment is very basic with PPIs. So you want to give them proton pump inhibitors, which are going to decrease the secretion of the gastric acid in the stomach, like omeprazole, or you can also give them histamine receptor antagonists. Okay, so Barrett's esophagus. So Barrett's esophagus, like I said, is one of the most common complications of chronic GERD. So when you have GERD that occurs like over a long period of time, such that the esophagus is getting irritated over and over again, then you have like metaplasia that occurs. So metaplasia is usually occurring in response to stress. So here the stress is the gastric acid. So usually you have the normal esophagus mucosa that is just lined by simple like stratified squamous epithelium, because all the stratified squamous epithelium has to endure is the friction of the food that you're eating. But it's not really suited to handle all this acidic content. So what happens is when there's this chronic stress, you have change in the mucosa such that the epithelium changes to this columnar epithelium now, which produces mucin. Like you can see in this picture, before it was just stratified squamous over here, just multiple layers of it, because this is the lamina propria here. So this is your epithelium, but later it produces this large columnar epithelium with these mucin producing cells. So this mucin will help in like neutralizing some of the acid that's present in that region because of GERD. So what also happens is that the transformation zone, which is basically where physiologically your stratified squamous epithelium changes to columnar epithelium in a normal esophagus, shifts upwards. So here you can see that if you do a GI endoscopy, you can see these projections wherein the metaplasia is happening. And this is what Barrett's esophagus looks like on an endoscopy. But you have to remember that because this is metaplasia, metaplasia is usually a reversible condition. So if you treat GERD, you can actually reverse the metaplasia such that the Barrett's esophagus doesn't progress to dysplasia and eventually progress into esophageal adenocarcinoma, because that's the complication. If you don't treat GERD, Barrett's esophagus is a metaplastic condition, so it will keep progressing till the cells actually become dysplastic and eventually they'll become cancer. And the most common type of cancer in this case would be esophageal adenocarcinoma, because the cells over here are gland producing cells. Okay, so you have to remember that Barrett's esophagus is one of the main complications of GERD. And in general, you can just treat it, like I said, with, again, PPIs, or you just try to decrease the risk factor. Like you tell them to stop smoking, tell them to stop drinking alcohol. You can even tell them to avoid big meals so that the stomach doesn't get distended enough for it to actually move up. Or in very severe cases, you can actually even perform a surgery wherein you resect a part of the esophagus, but that's again very severe. So the next condition we're going to talk about is achalasia. So achalasia, as the name suggests, is achalasia. So A is without, chalasia is relaxation. So here the clinical picture is kind of opposite to that of GERD. So in GERD, you had the lower esophageal sphincter, which relaxed too much. Over here, the lower esophageal sphincter doesn't relax at all. So when it doesn't relax at all, even during meals, your food that you're eating doesn't get to move into the stomach at all. So it kind of presents with this triad of pathology, which is incomplete relaxation of the lower esophageal sphincter, because of which you have increased tone or increased pressure in the gastroesophageal junction. And because of this buildup of food that will occur eventually, the esophagus just becomes aperistaltic. So it doesn't have any peristaltic movements at all. So in general, you can have achalasia because of primary or idiopathic reasons. So that's the most common form of achalasia, wherein it just occurs without any underlying pathology. And in this case, the problem happens because there's a damage to the myenteric plexus. So the myenteric plexus is usually present in the walls of your esophagus, but if there's damage to that plexus, then it's not able to relax at all, because of which it produces achalasia. Now, you can also have achalasia as a secondary condition because of some already existing pathology. For example, in Trypanosoma cruzi infections, you have dilation of a lot of structures, like even your you have dilated cardiomyopathy, dilated esophagus, megacolon. So in this case as well, you have dilation of the esophagus and no relaxation of the lower esophageal sphincter. Like I mentioned at the start, because this is a motility disorder, it's not that anything is obstructing it. Here, the motility because of the myenteric plexus is damaged. So here you'll have dysphagia to both solids and liquids. So both of them are not going to be able to pass down. You're going to have retrosternal pain, like epigastric pain, heartburn, regurgitation, and obviously if it builds up a lot, you're going to have halitosis. Halitosis is just the technical term for bad breath. So when you have all this food that like accumulates in the esophagus, it's obviously going to rot eventually, which was going to lead to the bad putrid breath that you have. And because of that, you can also have frequent hiccups. And the way that you diagnose this is with something known as a barium swallow. So you give them oral barium, and then you do a X-ray scans. You would see this, which is typically known as a bird beak sign. So you have accumulation of all this contrast material proximal to the gastroesophageal junction and the lower esophageal sphincter because of the aperistalsis of the esophagus. So this is the bird beak sign, which is very common and very important to be seen in achalasia. Other than that, you can also do manometry. So manometry is basically pressure monitoring. So if you check the pressure over here, like I said, the tone or the pressure of the lower esophageal sphincter is going to be extremely high. So on manometry, you're going to see increased pressure than what is normally supposed to be there at the lower esophageal sphincter. Treatment, so usually you just start with basic pharmacological treatment, but that's only for short term. So you can use any kind of relaxation ones like nitrates or calcium channel blockers, but more definitive treatment is with the pneumatic dilation, or you can also do a Heller's myotomy, which is basically when you just take out some of this muscle of the lower esophageal sphincter so that it's able to eventually pass through. But this is obviously risky because it can increase your chances of GERD if you cut it too much and it relaxes too much. So you have to see it carefully. Next thing we're going to talk about is hiatal hernia. So hiatal hernia is the abnormal protrusion of a portion of a stomach into the thoracic cavity through a lax diaphragmatic hiatus. So in general, hiatal hernia can be of two types. So it's basically when you have the stomach, which is usually present below the diaphragm, but it's moving up. So you can either have a sliding hiatus hernia or you can have a paraesophageal hiatal hernia. Again, the risk factors for these are going to be anything that increases your intra-abdominal pressure. So it's very commonly seen in obese people. It's also very commonly seen in pregnant people. So here you have the sliding hiatus hernia, which is basically when the stomach just kind of gets pulled up. So it's not that it's just moving up. So the lower esophageal sphincter is also moved up such that the gastroesophageal junction becomes a straight tube now. It's not bent anymore, which is actually bad because it can increase your risk of GERD, and because of GERD you can have ulcerations then. So like it says here, the gastroesophageal junction and the gastric cardia just slide up, so you're able to see this kind of hourglass pathology, which is what you would see on imaging, like on an X-ray scan. Or you can have the second type, which is the paraesophageal hiatus hernia, and in this case it's known as a rolling hernia because it's not that the gastroesophageal junction is moving at all. Its anatomical position is still the same, but it's just that the portion of the stomach moves up. The gastric fundus, which is present here usually, it herniates through the diaphragmatic hole right next to the esophagus. That's why it's para-esophageal. And in this case, obviously, because you're decreasing your stomach lumen, because you can't really digest and store food in this part of the stomach, you are going to present with early satiety and pain. So early satiety is like when you try to eat but you get fuller than you usually would. So that's one of the main presentations. So hiatal hernias in general are like a fairly common condition, and you can see it a lot in like old people as well. And in general, you can also kind of imagine that if you try to auscultate the lung at this point, you would be able to hear some kind of like bowel sounds or like acid splashing in this area, which is also very characteristic for paraesophageal hernias. Treatment is just lifestyle modification. So if they're obese or if they're smoking, then you should just tell them to stop it. PPIs again, because like I said, here there's an increased chance of GERD, so you give them PPIs, or you do surgery, which is a hiatoplasty. So it's usually because this diaphragmatic hole that the esophagus passes through, it's too lax. So you can just do something to increase the tension of it, like kind of push the hernia down first and then increase the tension over here so that it doesn't keep sliding up, because it can have a lot of recurrence if you don't treat it properly. Okay, the next topic we're going to cover is diverticula. So diverticula is basically a small outpouching along the walls of any kind of hollow structure. Okay, so as you can see here, this is the normal lumen of your GIT. It can be any portion of the GIT. It can be in the esophagus, it can be in the duodenum, it can be in the jejunum, it can be in the colon. So in general, any kind of hollow organ, and you have this small outpouching that occurs here. Okay, so you basically have two types of diverticulars. You can have true diverticula, or you can have false diverticulars or pseudo-diverticulars. So true diverticula is basically, like you can see here, all the layers of the colon or all the layers of your GIT are there in this outpouching. All of them move out. So you have the serosa, the muscular layer, the submucosa, and the mucosa. All four of them are moving out. Whereas a pseudodiverticula, only the mucosa and the submucosa layers kind of protrude out through the muscular layer. So the serosal lining is still there, but like you can see, the muscular layer ends over here. It's not really forming one of the walls of the diverticula. That's the main difference between false and true diverticula. So in general, false diverticulars are a lot more common because they happen because of increased intraluminal pressure. So they're also known as pulsion diverticulums. So pulsion basically means there's some kind of force that's pushing this layer out, and it's usually some kind of intraluminal force that's happening. Whereas you have true diverticulars wherein you have some kind of external force that's pulling it. So they're known as traction diverticulums. That's why you have all the layers that are moved out. Does that make sense? So you have this, which is pulsion, false diverticulum, or you can have traction, true diverticulums. So true diverticulums are not that common. One of the most common ones that you'll have to know is the Meckel's diverticulum, which we will talk about later. But yeah, false diverticula are more common, and you will see them in the colon, in the esophagus, like we're just going to talk about now. So like I said, these pulsion diverticulums happen because of increased intraluminal pressure. So that's going to happen if you have a diet which is very high in fat, or very high in red meat, or if you're not eating enough fibers. So if you're not eating enough fibers, there's not a lot of fibers basically help the food to move more smoothly through the GIT. So if you have less fibers, it's kind of going to get very constipated and slow, because of which it's going to increase the luminal pressure and actually cause a false diverticulum. So esophageal diverticula. Esophageal diverticula can happen at many levels. It can happen at the upper esophageal level, the middle esophageal level, or the lower esophageal level. But the most important one you have to know is this Zenker diverticulum. And Zenker diverticulum is in the upper esophageal region. Like I said, it's a false diverticulum, so it only contains the mucosa and the submucosa. So if it's a false diverticulum, it's obviously happening because of pulsion or increased intraluminal pressure. So intraluminal pressure can contribute to diverticula, but also you have to remember that it has to be at some area where the wall is very weak. So in this case, in the esophagus, you have this weak area which is just above the cricopharyngeal muscle. So you have the upper esophageal sphincter here somewhere, And just proximal to that, you have this area of weakening in the hypopharynx, which is where the mucosa and the submucosa will kind of come out from and form this outpouching. Okay, and this area of weakening is in the anatomical space known as the Killian triangle. But basically, you just need to know that it happens in the area proximal to the upper esophageal sphincter, and it's a false diverticulum. So it only contains the mucosa and the submucosa. The symptoms, obviously, they're going to present with dysphagia. So if you have this pouch, it's not going to be very easy for you to swallow food. You're going to have halitosis. Like I said before, the food is going to build up over here. It's going to rot, which is going to lead to this bad putrid breath. Regurgitation. So obviously this food can also move out, because even though it's here, the peristalsis will still go on, so the pressure can make the food come in. You're going to feel retrosternal pain, and if it actually moves out and comes into the trachea over here, it can cause pulmonary symptoms like aspiration or aspiration pneumonia. So this is the main one that you have to see. The diagnosis is again through the barium swallow. Like for most GI pathologies, you will either do a barium swallow or an endoscopy or a colonoscopy if it's a lower GI problem. So in this case, if you do a barium swallow, like you see here, you can see this collection of the contrast again. So this is going to be your diverticulum. The other diverticula, like I told you, they're very rare. So you have the middle esophageal diverticulum, which is basically at the tracheal bifurcation. Okay, and this is a traction type. So if it's a traction type, it's most probably going to be a true diverticulum. And the traction in this case is provided by some kind of pathology in the mediastinal area. So it can be any kind of like tumor or inflammation or lymph nodes or anything like that that is kind of pulling it from the outside, which is going to cause the traction and cause a middle diverticulum. The lower diverticulum is the epiphrenic one. So epiphrenic means just above the diaphragm. So just before the esophagus goes into the diaphragm, you can have a diverticula, and this is usually a false diverticulum. So it's only the mucosa and the submucosa. For example, any kind of intraluminal pressure increases, for example, in like achalasia. So you can have this lower diverticulum, which is the epiphrenic one. Treatment for most of these is just surgery. So you just have to go in and you have to kind of take it out and then like fix the wall again, which is going to be one of the mainstay of treatment. Okay, then you have some smaller, less important non-neoplastic diseases, which is like you can see here, esophageal webs and esophageal rings. So these are basically two structural abnormalities. So the main difference between esophageal webs and esophageal rings is that an esophageal web is not going to be circumferential. So like you can see in the picture here and the picture here, it's only coming out from one side over here. Whereas you can see the ring, this is the normal lumen, whereas the ring is like all over, right? So an esophageal web is only going to be on one side, whereas an esophageal ring is going to be circumferential. So esophageal webs are just thin protrusions of the mucosa. Like you can see, like it looks very thin and friable here. So it's only the mucosa that's kind of coming out and forming this fold or this web kind of thing, as you can see in this picture. And it's most commonly found in the upper esophagus. The main thing that you need to know about esophageal webs is that they occur in something known as the Plummer-Vinson syndrome. So the Plummer-Vinson syndrome is a syndrome wherein you have this classic triad where you have severe iron deficiency anemia, these esophageal webs, and also atrophic glossitis. Atrophic glossitis is basically when your tongue becomes very beefy and red. And so if you see someone with iron deficiency anemia, you always have to check them for esophageal webs, or if you see that their tongue is very like atrophic and red and beefy, then you suspect Plummer-Vinson syndrome. And the reason why these esophageal webs are important is because they increase your risk of esophageal squamous cell carcinoma. So you basically have two types of esophageal carcinomas. You can either have adenocarcinoma or squamous cell carcinoma. So this increases your risk for squamous cell carcinoma versus GERD and Barrett's esophagus, which increases your risk for adenocarcinoma. Yeah, so just remember that the esophageal web are not circumferential, and in the upper esophagus you typically see it in like older women, and the most common association is the Plummer-Vinson syndrome. Okay, then you have something known as the esophageal Schatzky ring. So esophageal rings, there can obviously be a lot number of esophageal rings at different parts of the esophagus, but the most important one you have to know is the Schatzky ring, which is, like I said, a circumferential narrowing. A web is just on one side. And it can be congenital, like a baby is just born with it, or it can be acquired as a result of chronic GERD. And in this case, again, it's going to cause dysphagia. And because it's a mechanical obstruction, you're only going to have dysphagia to food. In both cases, you can see that they're not really going to have problems with liquids, but it's going to be more the solid components of food that are going to be hard. And in rare cases, it can cause complete obstruction. Like if this keeps growing, then it can lower the, decrease the lumen by a lot, which is going to cause this complete obstruction. Same thing over here, you can see a barium swallow, and you can see this ring, and you can kind of see it on both sides, which means that it's going circumferentially, whereas if it was just on one side, then it would have been an esophageal web. Okay. The next thing we're going to talk about is esophagitis. So esophagitis is basically just inflammation of the esophagus. We spoke about reflux esophagitis, which is basically a special type of esophagitis which occurs in GERD. This is just general inflammatory esophagitis. So the first one that you have is infectious esophagitis, wherein you basically have some kind of microbe, which can be a bacteria, a fungi, a virus, which is causing inflammation. And you generally only see this in very immunocompromised patients. So for example, if they're transplant patients or HIV/AIDS patients, they're more susceptible to these kind of infections in the esophagus. And you really don't see it that much in people that are healthy and immunocompetent. So the most common one is Candida. So Candida, when it affects the esophagus, you can see here, they form these pseudomembranes, just like Candida forms in every other part of the body. So these pseudomembranes will look like white plaques, and you should be able to scrape them off, which is how you would differentiate it from a more premalignant leukoplakia lesion. It's the same way as it is in the mouth or the tongue. Then you can also have HSV1. So HSV1 is herpes simplex virus, which is going to have the same presentation as it did in the mouth. So it's also going to have these superficial punched out ulcers, same way that it would present on the lips or in the tongue. And finally, you're going to have CMV, which is going to show these shallow linear ulcerations. So CMV is cytomegalovirus. So instead of these pseudomembranes, just imagine if there were tears, linear tears. That is how CMV would present. Okay, then you have chemical esophagitis. So chemical is because of some chemical. So it's when you ingest some kind of strong acid or strong base. So people in suicide attempts, if they try to drink bleach or something like that, then they would develop chemical esophagitis. It can also occur because of smoking, because again, chronic irritation, and alcohol or hot drinks, chronic consumption of alcohol or chronic consumption of hot drinks in the same way. But obviously the most common reason for it is going to be strong acid or strong base. It can also be caused by some kind of medications. So NSAIDs in general, if you take chronic NSAIDs, like if they're a heart patient and they're on chronic NSAID therapy, then they are also susceptible to generating chemical esophagitis. And finally, you have eosinophilic esophagitis, so which is a immunological mediated disorder. So it's basically associated with atopy. So it occurs with all of the other atopic conditions, so rhinitis and asthma along with that. So it's basically having some kind of underlying allergic disorder. For example, it can occur because you have some kind of food allergy. So, and if you don't know about it, or if it's not that apparent, but you keep eating it, then it's going to cause this kind of eosinophilic inflammation in your esophagus, which is going to be seen as eosinophilic esophagitis. And you're going to present with the same symptoms. So dysphagia, heartburn, and food impaction if the inflammation is a lot. So this here is a picture of eosinophilic esophagitis, when you have inflammation throughout the lumen of the esophagus, throughout the length of the esophagus as well. So yeah, that's all the types of esophagitis that we're gonna talk about. So mainly you have to know in eosinophilic esophagitis is that they can also have other allergic conditions. So atopic dermatitis, rhinitis, asthma, and you basically have to put them on some kind of dietary restrictions to prevent the exposure to that food allergen. So you have to find out what kind of food they're allergic to and then tell them to abstain from it. Or you can also give them some topical steroids in order to decrease the inflammation that's happening throughout the esophagus. Okay, Then you have some vascular pathologies. So vascular pathologies, the main one you have to know is esophageal varices. So varices are basically these dilated, tortuous kind of submucosal veins that you can see, which are actually very, very fatal and very dangerous. So they mainly occur as a consequence of portal hypertension. So any kind of condition that leads to portal hypertension will cause dilation of these submucosal veins in different areas. So one of the areas that you see is the esophagus, where it presents as varices. Another place that you can see it is in the lower part of the rectum, where they present as hemorrhoids, or you can also see it in the paraumbilical veins, where it presents with caput medusae. So here you have esophageal varices. Like you can see here, this is the normal portal vein, and this is the inferior vena cava. So here you have a cirrhotic liver. So the circulation, the blood is not really able to go through the liver itself. So instead, it's going to get it's going to back up in this left gastric vein and the lower esophageal vein, like you can see here. So when it builds up in these submucosal, very thin friable veins, like veins have a very thin wall. So you can see it as these extremely dilated, tortuous ones, and you can see it very easily on upper endoscopy. And these are going to be one of the most common causes of severe upper GI bleeding. Like I said, it's a very dangerous and fatal condition. So you have to make sure that if you know that a person has cirrhosis, you have to keep checking them that they don't develop varices, because if these varices burst and leads to GI bleeding, which can present with them either vomiting blood or them having blood in the stool, which is hematemesis or melena, it could be fatal if you don't treat it. So yeah, if you do an upper GI endoscopy, this is what you're going to see. Then you have something known as Mallory-Weiss syndrome, which is quite rare, but it's very characteristic because it has these linear tears. So you can see in this picture, you have these linear tears that are present along the surface of the esophagus. So they're going to be mostly associated with forceful repetitive vomiting. So this kind of retching is usually seen in alcoholism. So people that are chronic alcoholics will vomit a lot. So if they vomit a lot, they damage the walls of the esophagus, which presents with these longitudinal lacerations. And this is obviously going to present with a lot of bleeding. So you will be able to see acute upper GI bleeding, and it's going to be extremely painful. So they would present with maybe anemia if it's like a chronic condition, or in some cases, if the tear is actually so severe that they're retching or they're vomiting so severely, then it could lead to a transmural rupture. And when it leads to a transmural rupture, there's a lot of loss of blood, which is something known as Boerhaave syndrome. So Boerhaave syndrome is when you have a spontaneous rupture of the esophagus, of the whole wall of the esophagus. So obviously you're going to have bleeding. Other than that, you're also going to have all this acid and all the gastric content that's going to be able to now move into the mediastinum. So it's going to cause mediastinitis, and all the air over here is also going to go into the mediastinum, which is usually it's not supposed to have any air. So you can also have subcutaneous emphysema. So if you try to do an auscultation, you'll be able to hear these characteristic crackles because of the emphysema. And this is again a very emergent condition that you have to treat with surgery immediately. Okay, so the next thing we're going to talk about is the diseases of the stomach and duodenum. So the two main conditions over here are peptic ulcer disease and gastritis. So peptic ulcer disease is when you have one or more ulcerative lesions that are present either in the duodenum or the stomach. And all these ulcerations are actually way more common in the duodenum than in the stomach, even though people usually associate PUD with the stomach. So what is a peptic ulcer? A peptic ulcer is when you have a defect in the gastric or duodenal mucosa, and it has a depth that actually reaches the muscularis mucosae. So an erosion is when you have just a surface epithelial lesion, but if the lesion actually goes below the surface epithelium and actually into the deeper layers of the mucosa or even the submucosa, then it's known as an ulcer. Okay, and peptic ulcer disease in general is very commonly associated with two conditions. That's either a Helicobacter pylori infection or chronic NSAID use. So in both of these conditions, you have an imbalance between the protective factors of the stomach, like the mucin and the bicarbonate that's usually produced, versus the acidic factors that are increased by these conditions. It can also happen in some other very rare conditions like the Zillinger-Ellison syndrome, wherein you have a gastronoma. A gastrinoma is a gastrin-secreting tumor that's usually present either in the duodenum or in the pancreas, and because it excessively produces gastrin, it increases the HCl production, and because it increases the HCl production, it can lead to the formation of peptic ulcers. So in general, gastric ulcers are caused by H. pylori because H. pylori secretes this special enzyme known as urease, which is able to convert urea into ammonia, which alkalizes the environment, and that's why it's able to actually survive in this extremely acidic gastric pH. So when H. pylori is present in the stomach, it attaches to the epithelial cells and it disrupts the mucosal barrier, which is why you have ulcer formation. And it's basically because of the same reason even in the duodenum. In terms of NSAIDs, so NSAIDs are basically drugs that inhibit COX-1 and COX-2, so they decrease prostaglandin, which is actually a protective hormone that increases mucus and bicarbonate production. So when you have prostaglandin decreased production, you have erosion of the gastric mucosa, and you have decreased blood flow to the mucosa as well. So all of these conditions basically cause an imbalance between the protective and the acidic forces, which is why you have peptic ulcer disease that happens in this setting. So risk factors, obviously smoking, heavy alcohol, both of these, they don't actually cause peptic ulcers, but if you already have peptic ulcer disease, it can be very hard for you to heal from them if you are a chronic smoker or a heavy alcohol drinker, because they delay healing. Other than that, glucocorticoids, caffeine, stress, they all have the same risk. They are all risk factors for peptic ulcer disease as well. So usually peptic ulcer disease can be asymptomatic, so the patients don't really present with any kind of symptom, but if they do, the most common thing they're going to be complaining of is epigastric pain, and they're going to typically define it as this like gnawing or burning pain in the retrosternal epigastric region, and peptic ulcer disease is like probably the second most common cause of epigastric pain after GERD. Other than that, it can cause dyspepsia, which is basically your indigestion, or you can have nausea and vomiting or bloating. So if you talk about stomach ulcers and duodenal ulcers, like I told you, duodenal ulcers are a lot more common. 75% of peptic ulcer disease is in the duodenum. So in the duodenum, they're very typically located in the anterior or posterior wall of the duodenal bulb. The duodenal bulb is the part that's just distal to the pyloric sphincter. So after the pylorus of the stomach, you have the duodenal bulb, and in the anterior posterior wall is where you usually find these duodenal ulcers. In the stomach, you usually find them on the lesser curvature of the stomach. Now, even though stomach ulcers are a lot less common, they actually have a much higher risk of malignant transformation, whereas duodenal ulcers are almost never malignant. Another thing is that because when you eat food, acid production in the stomach goes up, so stomach ulcers are usually associated with increased pain, increased epigastric pain while eating. That's why people tend to eat less, and it's associated with weight loss. Whereas the pain in duodenal ulcers decreases while eating, and that's why people tend to eat more, and it's associated with weight gain. But these pain associations aren't definitive, and you can have different patterns in stomach and duodenal, so don't rely on them, but this is the general pattern that you can see. Other than that, you can have two kinds of ulcers. You can either have benign ulcers or malignant ulcers. So malignant ulcers are more common in the stomach. So they will be typically seen with like these heaped up edges and a necrotic base. Otherwise, the normal peptic ulcers usually just have a regular margin and a clear base because your stomach is constantly moving. So nothing really deposits in the base of the ulcer. But if it's a malignant ulcer, there's going to be a lot of necrosis. The mucosa around a benign ulcer is just going to be edematous because of the inflammation, whereas the mucosa around a malignant ulcer is going to have a lot of nodules and scarring because of the cancer progression. So you just diagnose them directly by either asking them if they are a chronic NSAID user. You test them for H. pylori, which you can do with either a breath test or serology, but the most definitive diagnosis is obviously endoscopy with the biopsy. You treat it with triple therapy. Triple therapy for H. pylori is basically when you combine proton pump inhibitors with antibiotics. And these antibiotics and PPIs need to be given for like 4 to 8 weeks. Other than that, if they're on NSAIDs, you try to reduce it or replace it, or in very severe cases, you can perform a gastrectomy. So there are a number of complications that can happen from peptic ulcer disease that you can see here. So bleeding. So if they actually erode through the mucosa or the submucosa, it can cause rupture of the arteries that supply them, which is most commonly the left gastric artery in stomach ulcers or the gastroduodenal artery in duodenal ulcers. and this would present with upper GI bleeding symptoms. So hematemesis, melena, iron deficiency anemia, or if it's very severe, shock. The most scary complication is perforation. Just like in the esophagus, you're going to have a full thickness rupture of the stomach or duodenal wall. So all the gastrointestinal content is going to leak, this time into the peritoneum, not the mediastinum. So it's going to cause peritonitis, which is going to present with an acute abdomen. And it's also going to cause shoulder pain, which is actually a very important sign because you irritate the phrenic nerve and the referred pain is in the shoulder. And this is a medical emergency, so you immediately have to take them into surgery and fix the perforated wall. Other thing is fistula. So fistula is when you have an abnormal connection between two organs. In this case, it would actually penetrate through the gastric or the duodenal wall into the liver or pancreas, which is again very immediately treated with surgery. And finally, you can have malignant transformation of the gastric ulcers. Like I told you, gastric ulcers have a very high risk of malignant transformation, and they cause gastric carcinoma, which is more commonly the intestinal subtype. So here you can see on top, this is a benign ulcer, which has a very normal clear base. You can see there's nothing deposited over here, and just the surroundings are just edematous. Whereas here you have a malignant ulcer, like you can see, it looks very fibrotic and scarred. There's so much necrosis that you can see, and there's a lot of nodules surrounding the ulcer as well. This over here is the sign of perforation, which is pneumoperitoneum, which is what you see when there's air in the peritoneal space, which presents as this lesion above the diaphragm. So if you see this on an X-ray, you have to take them into surgery immediately because it means that there's some kind of perforation in the peritoneum. Then you have gastritis. So gastritis is when you have acidic damage due to the imbalance between damaging and protective factors. So this is the same etiology as H. pylori and NSAIDs, but it's when it occurs in an acute setting. So the risk factors are going to be same: H. pylori infection, NSAIDs overdose, smoking, heavy alcohol consumption. But the two special types of ulcers that you should know are the curling ulcers and the Cushing ulcers. So curling ulcers occur when there's a severe burn such that you have hypovolemia, because of which your blood supply to the stomach is decreased, and as a result of which you have ulcers, or increased ICP, again a stress reaction, so decreased blood supply to the stomach leading to the formation of a Cushing ulcer. So these are two key words that you need to know. So because this is an acute gastritis, so you can either have only superficial inflammation, which is just going to present with redness and hyperemia. You could have erosions, like I said, that's just loss of the epithelial layer. Whereas if it goes deeper, then you can actually have ulcers that goes all the way through the muscularis mucosa as well. And in most cases, the presentation is going to be basically similar. So you're going to have hematemesis, melena, IDA, epigastric pain, dyspepsia, early satiety. So here you can see that there's a normal protective and damaging factors, but when the balance is disrupted by these factors, you can have increased damage or impaired defenses, because of which you have acute gastritis. Then you have atrophic gastritis or chronic gastritis, which is basically of two types: type A, which is most commonly associated with autoimmune gastritis, or type B, which is associated with H. pylori. So the more common type is H. pylori, because anytime you think of any kind of stomach or duodenal problem, H. pylori is always going to be one of the causative factors. So in this case, it's the most common cause of chronic gastritis, where you have, like I said, colonization by H. pylori, which it prefers to sit in the gastric antrum because there's less acid over there. It's characterized by achlorhydria, hypergastronemia. That's common to both of them, to both types of atrophic gastritis. Achlorhydria is when you have decrease in HCl production, and hypergastronemia is when you have increase in the gastrin production. Autoimmune gastritis is the less common cause of chronic gastritis. Here is where you have an autoimmune condition that destructs the gastric parietal cells, and then you have a subsequent reduction in the amount of gastric acid. So here you have autoantibodies against intrinsic factor as well. So it's going to present with vitamin B12 deficiency, because as you know, intrinsic factor is very important for the absorption of vitamin B12. So when you have vitamin B12 deficiency, you have a special type of anemia, which is pernicious anemia, which is megaloblastic. So they're going to present with typical symptoms of anemia like pallor, fatigue, and in this case the lesions are confined to the gastric body and the gastric fundus, which is where the parietal cells are. So the distribution of autoimmune gastritis depends on the distribution of parietal cells. That's why it's more common in the gastric body and the fundus. And the complications is gastric adenocarcinoma, Treatment is that the main pathology in this case is the vitamin B12 deficiency, so you just treat it with vitamin B12, or you try to give them some immunosuppressive medicines to treat the autoimmune part of it. So H. pylori gastritis is basically has the same clinical picture as PUD, so you're going to have recurring ulcers. Like I said, in H. pylori gastritis, it depends upon the distribution of H. pylori, so here it's going to be more common in the gastric antrum, and then it's going to spread to the entire body as well. Complications in this case is gastric cancer, and because it's a chronic infection, so you're also going to have increased risk for MALT lymphoma, which is mucosal associated lymphoid tissue lymphoma. And the treatment for it is basically same, so you just treat them with triple therapy for H. pylori. Okay, the next thing we're going to talk about is inflammatory bowel disease. So inflammatory bowel disease, as the name suggests, is a chronic relapsing inflammation of the bowel. So you have these recurring episodes of inflammation that happen at different parts of the bowel depending on which disease we're talking about, and it's a chronic condition, so it extends over years. The main thing about this is that it's idiopathic, so we have no idea what the etiology is. Some people believe that it's some kind of underlying infectious cause or autoimmune, or there's some kind of combination of the two, but overall it's idiopathic. And lastly, it's a diagnosis of exclusion. So the basic symptoms that present in inflammatory bowel disease are common with many other GIT disorders, like infectious or ischemic ones. So the only way that you can actually diagnose someone with IBD is if you exclude all the other diseases with an endoscopy and a biopsy, and then you have positive findings for IBD. So the two main types of IBD is Crohn's disease and ulcerative colitis. So they actually have a lot of differences, so we can just compare them right now. So you have Crohn's disease over here, which usually presents with skip lesions, whereas ulcerative colitis is mainly in the colon, mainly in the rectosigmoid colon, and it's continuous involvement. And there's a lot of other differences as well, which we can see in this table here. So if we start by talking about ulcerative colitis always involves the rectum, and it's the more common type of IBD. So morely common is ulcerative colitis and then Crohn's disease. So it always involves the rectum, and it's going to extend proximally in a continuous fashion to involve the rest of the colon. So like you can see, it's always going to begin in the rectum, and it's going to then continuously go up proximally to involve the rest of the colon. And even if it extends, it's going to extend all the way, but it's never going to go into the small intestine. So it would extend, and the most it could extend is to the ascending colon or the cecum over here. It's never going to go into the small intestine. So that's one of the defining features of ulcerative colitis. So here you'll be able to see, as the name suggests, it's ulcerative, so you're only going to see mucosal and submucosal inflammation. So you're going to only see ulcers, which are going to extend into the mucosa and the submucosa. The involvement is going to be continuous, which is one of the main differences from Crohn's, which can have skip lesions. And it only involves the colon, like the name suggests, so the remainder of the GIT is unaffected. So because the most common part of the GI that is affected in ulcerative colitis is the sigmoid colon or the rectosigmoid region, patients are most typically going to present with left lower quadrant pain and bloody diarrhea. Bloody diarrhea, again, because of the ulcers, and it's something that you need to know very importantly, because it's also something that differentiates it from Crohn's, which is usually with non-bloody diarrhea. The next thing is that the most typical microscopy that you're going to see is crypt abscesses and neutrophils. So you're going to have the normal crypts of the intestine, and they're going to be filled with neutrophils, and they're going to have these abscesses with no granulomas, which is what is important, again, because Crohn's disease usually presents with granulomas. The gross appearance, if you do an endoscopy, you're going to see pseudopolyps. So you're going to see these polyps, these lesions that look like polyps, but they're pseudopolyps, and you're going to have loss of haustra. So haustra are these normal lesions, these normal foldings of the colon that you can see. But when you have ulcerative colitis, you have loss of these haustras, and the most typical sign is the lead pipe sign that you see on imaging. I have a picture of it on the next page. So this lead pipe sign is very characteristic. There are a number of complications associated with ulcerative colitis, the most important of which is toxic megacolon. So toxic megacolon is when you have increase in the lumen of the bowel, and this increase in the lumen of the bowel can damage the muscula propria, and the dilatation can have a significant risk for perforation. So if it keeps dilating, at one point it's not going to be able to dilate anymore, so it's just going to perforate, which can cause peritonitis, and it would have the same presentation as we spoke about before. And the other thing is carcinoma. So it also has a very high risk of developing colorectal carcinoma, and the risk of this carcinoma is based on the extent of the colonic involvement. What does that mean? So if it only involves the rectum, you probably have a lesser risk than if it involves the whole descending colon and the transverse colon. And it also depends on the time or the duration of the disease. So if you have ulcerative colitis for a period of more than 10 years, your risk is significantly increased. There are a number of associations. So almost all almost all patients that have primary sclerosing cholangitis are going to have underlying ulcerative colitis. Now remember that all ulcerative colitis patients don't have primary sclerosing cholangitis. Only like 5% of them have this condition. But if you see someone who has this, 95% of them are going to have ulcerative colitis. And you also have these particular markers that are P anchors, which are going to be positive for ulcerative colitis. Another thing is smoking. So this is like a funny association, but smoking actually protects you from ulcerative colitis, and there's no we don't know why, but it's just something that you can remember, because smoking actually increases the risk of Crohn's disease. Yeah. So then if we talk about Crohn's disease, in contrast to ulcerative colitis, it's going to present with skip lesions, which is very important because this is continuous, this has skip lesions, and the most common site of involvement for Crohn's disease is this terminal ileum cecal area. So this is the most common site of involvement. In a lot of cases, the rectum might even be spared. And unlike ulcerative colitis, it's going to be a full thickness inflammation with knife-like fissures. So it's not going to be just on the surface, it's going to go through the entire thickness of the bowel wall, through the submucosa and the muscular layer, maybe even into the serosa. And it's going to have these deep knife-like fissures, so it's going to go all the way through the wall. Like we said, it's skip lesions, and it can affect any part of the GIT, from the mouth till the anus. The most common site of involvement is the terminal ileum, and the rectum is least common. Like I said, if you have rectal sparing and you suspect IBD, then it's most commonly going to be Crohn's disease, because ulcerative colitis will always involve the rectum. So because it's the terminal ileum, they're going to have right lower quadrant pain and non-bloody diarrhea, because there's a lot of scarring and inflammation because of the full thickness inflammation. So the blood vessels are going to be scarred, so you're going to have non-bloody diarrhea. You're going to have granulomas, which is very important, because you wouldn't see any granulomas in ulcerative colitis. Then you have something known as cobblestoning of the mucosa. So because of the continuous healing and damage that happens in case of Crohn's disease, you're going to have this cobblestone mucosa, where you have some parts of the mucosa that are spared, and then some part of the mucosa that's actually affected by the disease, which can also be one of the manifestations of the skip lesions. And so this continuous full thickness inflammation leading to healing is also going to have strictures, wherein your colon lumen is going to reduce. So on imaging, you're going to see this classical string sign, which we can also see a picture of in the next one. It has a number of complications. So because it can involve any part of the GIT, if it involves the small intestine a lot, it's going to cause malabsorption, because that's where you absorb most of your nutrients. One very important complication is nephrolithiasis, which is basically kidney stones, and these kidney stones are of the calcium oxalate type. Other than that, you can have fistula formation, which is, again, like I said, because of the full thickness inflammation, it can actually go beyond the wall and attach to some other structure, like maybe the bladder. So you can have actually a colovesicular fistula, which can form in this case, which we'll also talk about later. And again, carcinoma only if colonic disease is present. So if it's just affecting the terminal ileum, you're not going to have an increased risk for colorectal cancer. Associations, so it's associated with all of these conditions. A lot of these conditions are common to both. So for example, something like uveitis or arthritis are actually common to both conditions. And lastly, smoking actually increases the risk for Crohn's disease, which is, like I said, something that's very important, because it's actually protective against Crohn's disease, protective against ulcerative colitis. So here you can see that Crohn's disease has this full thickness transmural inflammation, whereas ulcerative colitis only has these small ulcers and then pseudopolyps, and then ulcers and then pseudopolyps. So these are not actually polyps, it's just because the mucosa is completely gone over here. It looks like it's a protrusion, but that's just actually the normal wall. That's why it's a pseudopolyp. Here you have the picture. So this on this side is Crohn's disease, where you can see this string sign because of the stricture, whereas here you have the lead pipe appearance. Here you have the normal intestine where you can actually see the house stress, but here, because the house stress are completely lost, you can see this lead pipe sign, which is very, very characteristic of ulcerative colitis. Here you can see the cobblestone mucosa, so this part is probably spared, and then this one is where you have some lesions, and then there's some healing happening, and you can see that the lumen is very narrowed. So here the lumen is basically non-existent, which is what you would see on the string sign. And then here you have the colon. So here you can see the proximal end, whereas this is the distal end. So you can see that the rectum is completely involved. You can see the ulcerations and the erythema. And as you go up, it's still there, but it stops at some point, because the proximal end of the colon is where it can like maximally extend till it's never going to go into the jejunum or the ileum. So you have the irregular transition. So suddenly it stops. Whereas with Crohn's disease, you could have this area affected, then this area, then this area affected. So it's not going to be a continuous lesion in that case. So you have to remember those are the two main types of IBDs. You also have to remember that because Crohn's disease can be anywhere from the mouth to the anus, it can have a lot of presentation. In the mouth, it can present as aphthous ulcers. In the esophagus, it can cause, again, erosions or ulcers or esophagitis. In the stomach, it can cause PUD. Same in the duodenum, also it can cause PUD. So it can have a lot of different presentations depending on which part of the GIT it's actually affecting. Okay, so that's all for IBD. So the next thing we're going to talk about is colonic diverticula. So diverticula, like we already spoke about, there's true and false diverticulum. So even in the colon, mostly they're false diverticula. So there's outpouching of only the mucosa and the submucosa through the muscularis propria. Like we already said, false diverticula are usually pulsion ones. So there's some kind of increased intraluminal pressure, which can be, like we said, because of red meat or decreased fibers, increased fat, or just in general uncoordinated peristalsis. But another thing that you need to remember, that in colonic diverticula, it can also happen especially in the parts where the muscle is traversed by vessels. So you can see all of these vessels coming in. So like at different points, if there's like a vessel, then those points would be weaknesses because the muscle would be weak there, and then it can form a diverticula in that place. So in colonic diverticula, you can have diverticulosis, which is just the presence of one or more diverticula. It's completely uncomplicated. The patient doesn't have any symptoms, and it's just an incidental finding when you do a colonoscopy or an endoscopy. The other type is diverticulitis. It's basically when you have diverticulosis with superimposed inflammation. So when there's inflammation of the diverticula, it's called diverticulitis, and this is mostly due to mucosal erosion. So because over here in false diverticula, you can see that the vessels would be very close to this surface. So if this diverticula keeps growing, it can cause pressure on the vessels and they can actually erode, and that can cause diverticulitis, exposing the underlying collagen, or it can be because of a fecalith. So if like a part of a feces comes and gets obstructed over here, that can also cause inflammation in that region. So diverticulitis is basically when it presents with some kind of symptoms. So diverticula in general is most commonly located in the sigmoid colon because it's the narrowest part of the colon. So if it's the narrowest part of the colon, it's going to have the highest intraluminal pressure by the food. So sigmoid colon is the most common location of it. It's usually asymptomatic. So that's why I said diverticulosis can just be an incidental finding, or if it actually progresses to diverticulitis, then it can present with abdominal pain, discomfort, or even painless hematochezia. So if there's mucosal erosion and the blood actually starts bleeding at this point, then it can present as fresh red blood in the stool, which is what hematochezia is, different from melena, which is usually from an upper GI bleeding, wherein you have the blood, the hemoglobin, which is actually digested a bit, so it presents as a dark tarry stool, whereas hematochezia is more like bright red blood in the stool. So diverticulitis would present with left lower quadrant pain, because like we said, the most common site of involvement is the sigmoid colon. Because it's an inflammation, it will always present with fever, leukocytosis, but usually no bleeding. So if you have bleeding, it's most commonly associated with diverticulosis, whereas if you have diverticulitis, the inflammation kind of scars the vessels, so you have no bleeding. It's kind of the same logic that we used in ulcerative colitis and Crohn's disease. So diverticulitis typically doesn't have any bleeding. If you have hematochezia, then it's usually because of diverticulosis. Diagnosis, again, now we're in the lower GI tract, so we're going to say colonoscopy and not upper GI endoscopy. You can also use barium swallow, which is what they've done here. You can see these small outpouchings, which have the accumulation of the contrast material. So these are the holes, and this is the actual outpouching. Here you can see the histology image of a diverticula. So here you can see the muscular layer is staying in its anatomical position, but the mucosa and the submucosa is kind of diving down. So this is the histological image of a false diverticula. Then you have treatment. So treatment usually is just bowel rest. So if you have someone with diverticulitis, you don't want to make them have any more food that might exacerbate the inflammation. So you just try to give them all their nutrition by IV. So that's nil per os. So bowel rest, no food that goes in through the mouth. You also give them analgesics because it can be extremely painful. And you try to give them a high fiber diet. Like I said before, if you have fiber, it makes the stool pass more easily through the colon. So it's not going to increase the intraluminal pressure, and it might decrease the recurrence of diverticula once you treat it, because generally diverticula do have a very high incidence of recurrence. You can also give them antibiotics because in diverticulitis you can have some kind of infectious agent as well. And finally, if it doesn't react to any of these treatments, then you just have to do a colectomy, wherein you just resect the part of the bowel which has the diverticula, and then that's the most severe, intense treatment if nothing else is working. So yeah, mostly in cases of diverticulosis, if it's not causing any problems, then you can just leave it and you don't necessarily have to treat it with anything. But if it's actually causing problems like in diverticulitis, then you actually need to resect it or do something in order to be able to treat it. The next thing we're going to talk about is the complications. So similarly, you can have hemorrhage. Like we said, in this picture you can see that the blood vessel gets eroded, which is going to present with lower GI bleeding, the most common manifestation of which is painless hematochezia. Okay. Second thing is fistula. Again, because it can erode through the entire surface, it can actually form the connection with another organ. So here you can see the sigmoid colon, and it's in very close proximity to the bladder, even though you might not think of it. So there can be an abnormal connection that's formed here, which is known as a colovesical fistula, which is actually very, very dangerous because it can present with extremely painful urination, which is known as dysuria. But other than that, you can also have the feces from the sigmoid colon that can move into the bladder. So you can have feces in the urine or air in the urine, and all of these are very painful and very dangerous. Other than that, you can also have recurrent UTIs because of the normal gut flora actually passing into the bladder, which is not normal bladder flora. Inflammation or diverticulitis we already spoke about. Abscess, so if it actually gets walled off, then it can form an abscess like you can see here in number 4. So abscesses usually present with persistent fever and abdominal pain. So even if you give them antibiotics, you put them on bowel rest, you've given them analgesics, and they're still not getting better, then it's probably an abscess, and you can also diagnose this with colonoscopy. And lastly, perforation. So perforation, like we've already talked about before, it's going to go through the entire wall. So it's going to cause peritonitis, fecal peritonitis in this case, which is again going to present with pneumoperitoneum or air above the liver and the diaphragm, and shoulder pain because of the associated phrenic nerve irritation. Okay, so these are the main complications that you need to remember. In this picture, you can see this is an endoscopic image, so you can see these holes, which is the entrance to the diverticulus, and this would be the radiographical image. The other non-neoplastic diseases are the positional disorders, which are mainly volvulus and intussusception. So volvulus is a twisting of the bowel. So here you can see the sigmoid colon has kind of been twisted, and here is what it would look like if you actually try to untangle it. So it's the twisting of the bowel along its mesentery. So it mainly occurs in areas where you have too much mesentery, and you kind of have this extra mesentery that is actually able to be twisted. And this is very commonly seen in the sigmoid colon in adults, whereas in children it's more commonly seen in the cecal region. So in adults they would present with left lower quadrant pain, but in children it would be right lower quadrant pain, and it presents very similarly to appendicitis. So if you have a child who presents with right lower quadrant pain, sometimes it can be volvulus, which is a lot easier to treat than appendicitis. So if you have this twisting of the bowel, obviously you can imagine there's bowel obstruction, so the food over here from the proximal segment is not going to be able to move into this distal segment, so that's going to present with abdominal pain. You're going to also have distension, so if there's all this food build up here proximally to the point of the volvulus, you're going to have a lot of distension and also bilious vomiting. And finally, because there's going to be a lot of blood vessels in this area, if you rupture those blood vessels, it could present with hematochezia, or because of this twisting, if they get compressed externally, then it can also cause ischemia, which can lead to the necrosis of this bowel. So that's a very serious complication. You can also have intussusception. Intussusception is basically telescoping of the proximal segment of the bowel into a distal segment. So like you can see, this is the proximal segment, which kind of gets pulled into the distal segment, and usually the reason for this happening is that there's some kind of leading edge near the green arrow here, and which is actually going to pull the bowel in when it's actually contracting normally for peristalsis. So in children, it's very commonly seen in the cecum or in the terminal ileum region, which is mainly because of some kind of lymphoid hypoplasia. So in children, there's a very high abundance of Peyer's patches, and these Peyer's patches can cause lymphoid hypoplasia. So the terminal ileum actually gets telescoped into the cecum, which is what you can see here. So this is the small intestine, this is the ileocecal valve where it's supposed to be normally, but it's kind of gotten telescoped up over here. In adults, it's mostly due to a tumor, so it can occur anywhere that there's a tumor. There's no like typical location, and again, just like a volvulus, it can cause obstruction. So you can imagine that food can't really pass through here, or the feces can't really pass through here, and ischemia. And one very specific type of stool that you can see here is the currant jelly stool. So if you see currant jelly stool, it's most commonly associated with intussusception. So those are the two positional disorders that you should know about. The next condition we're going to talk about is ileus. So ileus is any condition where you have disruption of the normal propulsive ability of the intestine. So the normal peristalsis of the intestine is damaged, and this can mainly be because of two reasons. You can either have some kind of bowel obstruction, which is why the peristalsis isn't happening, or it can be a paralytic ileus, wherein it's like more of a neurogenic traumatic issue. So bowel obstruction is when you have an interruption of the normal passage because of some kind of mechanical structural barrier, which can either be internal, so you can have some kind of colorectal carcinoma or polyp or Crohn's disease, which is called all this scarring inflammation, because of which you can't move the food down and the peristalsis isn't happening, or it can be external, like adhesions after surgery, or intussusception is the most common cause. Then you can have paralytic ileus, wherein you have temporary impairment because there's no mechanical obstruction. So this can be traumatic, which is the most common cause of paralytic ileus, or it can be neuropathy or myopathy, which causes paralytic ileus. So the main thing you have to remember that there is no kind of mechanical obstruction over here. It's some kind of intrinsic neuropathic problem. Whereas in bowel obstruction, there's a very obvious structural barrier. The most common cause of ileus in general is post-operative ileus. So after like a very big or very small abdominal surgery as well, it's very normal for the bowel to just be aperistaltic, but this should usually self-resolve in 2 to 3 days. If it doesn't self-resolve in 2 to 3 days, then you have cause for concern. But otherwise, it's very normal for the post-operative ileus to occur, and the normal resumption of the bowel activity happens within a couple of days. Like it takes a shorter amount of time in the stomach and then a longer amount of time in the colon. And other than that, you can also have it caused by some kind of drugs like opiates. It can be because of hypokalemia, acute pancreatitis, like we said, IBD or Crohn's disease can cause bowel obstruction, or even acute pancreatitis, which would be more the paralytic type of ileus. And typically, because you don't have any peristalsis, you're going to present with constipation. So you're going to feel very constipated. There's going to be pain, nausea, vomiting, distension, and decreased bowel sounds. So if you try to auscultate the bowel, you're not going to be able to hear the normal bowel sounds. So on diagnosis, if you do an X-ray, you're going to see diffusely dilated small and large bowel loops. So this is very dependent on what kind of pathology it is. So if it's paralytic, it's going to be throughout the intestines, whereas if it's obstruction, then you're going to have dilation proximal to wherever the obstruction is. The treatment for it is basically the same. So bowel rest, nil poros, you just give them IV nutrition. You do electrolyte correction or cholinergic drugs. So cholinergic drugs would increase the parasympathetic activity and therefore increase peristalsis. One special type of kind of localized temporary ileus that you can know about is Hirschsprung disease, which is a congenital disorder wherein the neural crest cells, they don't really migrate into the bowel wall at all. So you don't have any myenteric or submucosal plexus. The baby is born without either of these plexuses in their intestinal wall, because of which the intestines are in a state of like constant contraction. So there's defective relaxation and there's no peristalsis of the rectum or distal sigmoid colon. That's the area that's affected. So it's localized. It's only in this rectum and distal sigmoidal region that you're not having the myenteric and submucosal plexus. The rest of the colon and the rest of the GI is normal. So it results in localized ileus and megacolon proximally. So in the area of the rectum and sigmoid colon, you're going to have ileus, so you're going to have no peristalsis, but proximal to that, you're going to have accumulation, distension, and megacolon. So in kids, this will mainly present with failure to pass meconium. So meconium is the first stool of the baby, and they're not going to be able to pass this. Other than that, they're also going to present with bilious vomiting. Okay, the last topic we're going to talk about is malabsorption syndromes. So malabsorption syndromes is characterized by impaired intestinal absorption of all types of nutrients. So it's basically when you can't absorb any of the food that you're eating. So you have decrease in carbohydrates, fats, proteins, vitamins, all kinds of nutrients. So it can basically have two mechanisms. It can either be insufficient absorption, so there's some kind of intestinal wall malfunction, like the villi are not working or the enzymes are not working, because of which you aren't able to take it up through the intestinal wall. Or it can be improper digestion, which is usually like an extraintestinal cause. So there's insufficient secretion of either the pancreatic enzymes or bile. So in general, insufficient absorption or malfunction of the intestinal wall can be classified as primary malabsorption syndrome, wherein there's actually some kind of enterocytic pathology of the intestinal wall. The most common forms of these are celiac disease, tropical sprue, lactose intolerance. Or then you have secondary MAS, which is when you have some kind of underlying infection which is causing malabsorption. So you have Whipple's disease, which is a kind of infectious cause, Crohn's disease, which is the idiopathic inflammation, IBD, or any kind of gastroenteritis, which is just damaging the intestinal wall. Or then you have extraintestinal one, which is what I said, there's an insufficient secretion of enzymes, which can either be an exocrine pancreatic insufficiency, bile deficiency, stomach inflammation like gastritis or something like that. So in general, no matter what it is, in the presentation of malabsorption is the same. So it's presented by chronic diarrhea. So you have increased stool mass and frequency. So your stool mass and frequency is increased. You have steatorrhea, which is the hallmark of malabsorption. Steatorrhea means increased fat in the feces. So generally you have decreased fat absorption, because of which you have increased fat excretion. So you're not taking in any nutrients, you're going to have weight loss and anorexia. You're not taking any protein, so you're going to have hypoalbuminemia, which is going to present with peripheral edema or peritoneal edema, which is basically ascites. You can also have dehydration and then vitamin deficiencies. So this is the other nutritional deficit. So if you have vitamin B12 or folate deficiency, it would present with anemia, which would be megaloblastic anemia, or then you'd have vitamin K deficiency, which would cause bleeding. And then you also have others like vitamin D would cause like rickets or osteomalacia or scurvy or something like that. And in the end, you also have increase in gas in your intestines, because of which you would have bloating or flatulence. Okay. So the first one we're going to talk about is celiac disease. So celiac disease is basically where you have a gluten-sensitive enteropathy. So in very layman terms, it's just gluten intolerance. And celiac disease, it manifests a lot more seriously in the duodenum than in the jejunum or the ileum. Okay, and it's basically that when you take gluten in, it's broken down into this compound called gliadin. And this compound gliadin is taken in by the receptor on the surface of your enterocyte, and it goes into the intestinal wall. And once it goes into the intestinal wall, because this is an autoimmune etiology, there's autoantibodies that are produced. And these autoantibodies that are produced are mainly of three types. You have the anti-gliadin ones, so it's directly targeting the byproducts of gluten. You can also have anti-TTG. Anti-TTG, TTG is the enzyme which breaks down gliadin into smaller compounds, and you also have anti-endomysial antibodies, which are EMAs. We don't know why exactly these are produced, but these are the three main antibodies that are present in celiac disease. And once you have inflammation of the intestinal wall, the way that it manifests into malabsorption is that all this inflammation damages the villi, which are usually present in the small intestine, which is why all these villi surfaces, which are usually all these pointy edges increasing the surface area for absorption, will undergo atrophy. So there's flattening of the villi, which is one of the main microscopic findings. Other than that, the crypts that are present below the villi are usually small, but they're increased a lot in their depth, so because of which it's known as crypt hyperplasia. And lastly, it's going to have a large number of lymphocytes in the epithelium. So as you can see here, these are the three manifestations that I spoke about. So usually you have these tall villi, which increase your surface area for absorption. They're flattened, so you have these flattened villi, because of which you have malabsorption and you're not able to take in nutrients. Other than that, you have these small crypts which are becoming hyperplastic, so you can see they're like long now. And finally, you can see all this lymphocytic infiltration in the epithelial layer. So it's basically an immune-mediated damage of the villi due to gluten exposure, and of the small bowel, the duodenum is affected more so than the jejunum or the ileum, which is something important to know because that's what differentiates it from tropical sprue. So it's highly associated with these haplotypes. So HLA-DQ2, this is going to be present in like 90 to 95% of patients, and DQ8 is present in like 5 to 10% of the patients. The typical patients that you find celiac disease with is either in infancy or in older adults. So it's either that they're born with it or they acquire it over time. Symptoms is going to be the typical malabsorption symptoms. So chronic diarrhea, steatorrhea, flatulence, bloating, pain are all like the common manifestation which happen in malabsorption anyway. So something that you need to remember, that gluten is commonly found in a lot of grains like wheat, rye, barley, and spelt. So the mainstay of treatment for these patients is just a strict lifelong gluten-free diet. So you just have to make sure that they don't consume any of these gluten-containing products, and along with them you also have to give them supplementation for all the nutrients that you're not taking in. So you have to give them iron supplements because otherwise they'll develop anemia, and also vitamin supplements, again the same, vitamin B12, B9, vitamin K, all the fat soluble vitamins actually, A, D, E, K, need to be supplemented in general. The diagnosis is by serology, so you can check for these autoantibody levels. So they're usually IgA antibodies, but in a lot of patients with celiac disease they tend to be IgA deficient. So in that case you have to look for IgG antibodies. You can do HLA testing, which will come up with DQ2 or DQ8, but finally the definitive diagnosis is going to be endoscopy with biopsy, which is where you're going to see these characteristic findings. It's associated with a number of conditions. Dermatitis herpetiformis is the most common association, wherein you have IgA deposition at the tip of the dermal papillae. So like I said, these anti-endomysial antibodies that are produced are also present in the dermis layer of your skin. So when these autoantibodies affect the EMA in the skin, it leads to the formation of dermatitis herpetiformis, which looks very similar to herpes, but it has nothing to do with herpes. You have to remember that these patients don't have any herpes simplex virus infection. This is just that it looks like herpes, that's why it's known as dermatitis herpetiformis. Lymphoma, so just like in Crohn's disease, you have like a lymphoma that's associated here, but here it's known as enteropathy associated T-cell lymphoma. You have to remember because a lot of the lymphomas are usually B-cell related, but this is a special one wherein it's a T-cell lymphoma. You can also have small bowel adenocarcinoma, which is when you have adenocarcinoma, which would be more commonly in the duodenum in this case. Refractory sprue, so celiac disease is called sprue, and then you have a special type which is tropical sprue, but if you say just sprue, it's usually celiac disease. So refractory sprue is basically when the patient has been on a long-term gluten-free diet, you know that they haven't been consuming any gluten, and still for some reason they have these malabsorption symptoms. So in that case, it basically means that their disease is kind of manifested again, and when this happens, it mainly tells you that there's some kind of cancer that's been developed, which can either be the small bowel adenocarcinoma or the Hiatal type of lymphoma. Okay, so those are the two main things. So if you have sudden exacerbation of symptoms in someone who has been on a long-term gluten-free diet, then you have to suspect that they now have adenocarcinoma or lymphoma. The other type of malabsorption sprue is the tropical sprue. So tropical sprue, it presents very similarly to celiac disease, but in this case it's thought to be of an infectious etiology. So there's some kind of infectious agent that's very prevalent in the tropical regions, which are like the Caribbean, India, or Southeast Asia, which is where this is typically seen. So it can either occur in residents that usually live in these areas or in travelers that go to these areas, but you have to remember that it has to happen over several weeks. It can't be that they just go on a 1 or 2 day trip and they get tropical sprue. It's usually like over several weeks of consuming food or like infectious agents that are there that you're exposed to. So in this case, again, it's going to present with chronic diarrhea, subsequent malabsorption, but it's associated with the tropical stay and suspected also to be of some kind of unknown infectious etiology. The way that is different from celiac disease is that it's very prevalent in the jejunum and the ileum, more so than the duodenum. The duodenum is not that involved. So because the jejunum and the ileum are affected, you're going to have a lot more severe malabsorption. But in this case, you also have to remember that jejunum is the main place where you absorb folate, and ileum is the main place where you absorb vitamin B12. Okay, so because of these two places being affected, you're not going to be able to absorb these two. So you're going to have a high risk of developing pernicious anemia or megaloblastic anemia. Diagnosis is the same as with celiac disease, and then treatment in this case, because we think it's an infectious agent, it actually responds to antibiotics. But you have to remember that you have to give it for a very long time because it's a very severe disease. And you also have to give them vitamin B12 and folic acid supplements. And like I said, it's a long-term treatment, so you have to do it for 3 to 6 months. So the main thing you have to remember here is that they both have similar features. Celiac disease, which is just sprue, and tropical sprue, they both present with steatorrhea, abdominal pain, weight loss, bloating, flatulence. But tropical sprue, if you actually diagnose it, you can treat it very easily because you can easily treat it with antibiotics. Whereas celiac disease wouldn't really respond to antibiotics. Then you have lactose intolerance, which is the inability to absorb lactose. So lactose is like one of the sugars that's created and that you ingest, and it's broken down by this enzyme lactase, usually into galactose and glucose. But when you have a deficiency of this lactase enzyme, you're not able to break it down. It's very commonly seen in Asia and Africa, and it's a lot less common in Western countries. So it's estimated that like 70% of the world population is actually lactose intolerant, but in Asia and Africa, this number goes up to like 80 to 90%. It will present with the same symptoms, so abdominal pain, flatulence, but in this case, you have to remember that they have watery diarrhea. Why do they have watery diarrhea? Because as soon as you take in milk and you don't break it down, all this lactose actually goes into your large intestine. So here you have your small intestine. You can see the villi where you usually have to break it down. But if you don't break it down, all that lactose goes into your colon, and in colon, because it's osmotically active, it's going to bring in a lot of water, and also it's finally going to be broken down by the flora over there, and it's going to produce a large amount of hydrogen, carbon dioxide, methane, which is why you have a lot of gas and bloating and flatulence as well that's associated with lactose intolerance. So that's you have primary lactose intolerance when you just have non-persistence. This is the most common type, because normally as well the lactase levels, they decline with age, which is the most common cause of lactose intolerance. You can have congenital form, which is extremely rare, wherein you're just born with a defective gene, so you don't have any lactase at all. Or you can have secondary ones, so you have some kind of gastroenteritis which has actually destroyed all the lactase, or celiac disease can also present with secondary lactose intolerance. So here you have to remember that you're going to have a normal intestinal architecture. You're not going to have any atrophy of the villi or crypt hyperplasia, no lymphocytes, nothing. Treatment, just like gluten intolerance, is just avoid or reduce intake of milk products. Recently, there's also been oral lactase supplements, so you can just take lactase and then consume milk products, which will help you break it down. You have Whipple's disease. Whipple's disease is a secondary malabsorption syndrome where you have a systemic infection with Trophorema whipplei. And because it's a systemic infection, it affects intestines, causing diarrhea. It would affect your joints, which it very commonly is associated with arthritis. Heart, it can cause valve defects, and when it affects your CNS, it can cause myoclonus or ataxia. So usually when you have an infection with Trophorema whipplei, it's taken up by the macrophages in your intestinal wall, but the macrophages are only able to partially break it down, And so these partially destroyed organisms are actually present in the macrophage lysosomes. So when you test for it with PAS, you can see this characteristic picture when you have all of these foamy macrophages that are positively staining for PAS. And it mainly presents in the small bowel lamina propria. So this is where you're going to see, this lamina propria is where you're going to see these PAS positive macrophages. And treatment is just with antibiotics, again, long-term treatment with antibiotics. Finally, you have extraintestinal malabsorption syndromes, which is where you don't have any kind of intestinal issue. Your intestinal wall is fine, all your enzymes are there, your villi are fine, but externally you're not getting the enzymes that are required for the breakdown of the nutrients and absorption. So the most common type over here is exocrine pancreatic insufficiency. So you have some kind of, and these are always secondary disorders, so you're not going to have exocrine pancreatic insufficiency on its own. It's going to be because of some kind of underlying pathology, which is most commonly chronic pancreatitis, like in alcohol consumption, cystic fibrosis, which is a congenital disorder. You're just born with decreased production of the chloride channels, or finally it can be because of cancer. So you have pancreatic carcinoma, because of which your pancreas aren't going to be producing these enzymes. So when they don't produce these enzymes, they don't get released into the intestine, and when they don't get released into the intestines, you can't break down fats, proteins, or vitamins, because the pancreas produce amylase, lipases, and proteases, which helps you break down all three main nutrients. Other than that, you're also going to have malabsorption of vitamins, because you're not going to be able to take in any of the fat-soluble vitamins, the ADEK ones, A, D, E, K. So this is the most common one. You can also have bile acid deficiency, which is again always because of some underlying pathology. So it's because of cholestasis. Cholestasis can be because of gallstones. So you have some kind of gallstones, so the bile isn't moving down. Cirrhosis, so which is causing compression of the bile ducts, or infections, some kind of cholangitis, primary sclerosing cholangitis, for example. And in this case, bile is very important for the emulsification of fats, so you're going to have a predominant fat malabsorption. So you're going to present with steatorrhea, which means that you're going to have increased amount of fats in the stool, and you're also going to have vitamin deficiency, which is mainly going to be of the fat-soluble vitamins, so your A, D, E, and K. And that's all for GIT pathology. Thank you so much for your attention. I hope you found it helpful. If you have any questions, you can always message me, and yeah, I hope you enjoyed it. Thank you so much for watching.